Hello, everybody. Thank you for joining me today on Navigating Life with a Child with Brain Injury and Scoliosis. I'd like to thank Rana for inviting me here, and then Alex Herman and his family for trusting me with this information and to share it with you guys. You'll see him in the slides. I hope I can enlighten you on some strategies and techniques to recognize scoliosis in your child and how to minimize the effects through early intervention, as well as some information on how to manage it day to day. So just a little bit about who I am. I've been a physical therapist for almost 25 years in the orthopedic world, and I have to admit that this is a little daunting because my background is not in traumatic brain injury, but in orthopedics. So as a physical therapist, I understand what's going on, but most of my treatments here today that I'm going to discuss, I tried my best to adapt to a wheelchair child. So if there's any more questions that need to be developed more specifically for your child, I'm happy to answer that. My goal is to provide you with a better understanding of what scoliosis is, what to look for, how to manage that curve, and some positioning that can be helpful when you get into the position where you already have scoliosis in your child. So what our agenda is going to look like is we're going to define brain injury and scoliosis, which I'm sure is preaching to the choir, but risk factors, signs and symptoms that you can look for if your child does not yet have scoliosis, diagnosis and early intervention, some treatment options, strategies for daily living, and then we'll wrap that up with some takeaways. So for our purposes today, brain injury refers to the damage to the area or areas of the brain that can be caused by traumatic circumstances such as a blow to the head, lightning strike, stroke, infection. It can range from mild to severe, and the effects will often depend on the location of the injury, the age of the child, and the severity of the damage. Some underlying problems that we see consistently are changes in cognitive function, emotional and behavioral changes, speech and language difficulties. Physical impairments can range from weakness and flaccidity to abnormal muscle tone. Muscle imbalances, changes in reflexes and sensation, as well as contractures, which then impact the postural alignment that your kids will hold when they're trying to sit and stand against gravity. With such an array of causes, obviously treatment and outcomes will also vary. When we look at scoliosis, on the other hand, it is a widely described condition, but what we seem to be able to agree on is that it is a three-dimensional curvature of the spine impacting all three planes. So the frontal plane, the way we look at the child from the back, the sagittal plane, the way we look at the child from the side, and the transverse plane is how the spine rotates. It is formally diagnosed with greater than a 10-degree Cobb angle, and it must have a combination of rotation, flexion, and side bending happening at the same time. As I mentioned, the three-dimensional nature of scoliosis means that the curve of the spine has flexion, side bending, and rotational components. That means that the treatment also has to be considered in a manner that goes beyond the traditional treatment of two-dimensional physical therapy. Non-specialized treatment options can miss managing all three dimensions at the same time, which can potentially lead to setbacks, wasted time, and further complications, especially in kids with rapid progressions or pain complaints. The spine does not simply bend forward or backward, left or right. It bends and curves and rotates in multiple directions in four segmented body blocks that must counter-rotate in opposite to one another and elongate to ensure maximal improvement. So in the Schroth method, which I'll talk about a little bit later in our slides, what you see here is you see the body broken into four body blocks. The shoulder and the head are considered one body block, the chest, another body block, the low back, the third body block, and the pelvis, another body block. And so what we see is those different blocks are trying to compensate for what's happening at the primary curve, which we'll talk about in a few slides. Stokes in 2003 described the biomechanical growth modulation cycle, which provides a framework for us to understand the development of progressive scoliosis. This theory explains that mechanical forces act on a growing spine that can modulate spinal growth, leading to the development of scoliosis. Specifically, it suggests that abnormal loading conditions can result in asymmetrical growth of the spine, which in turn perpetuates the spinal curve. According to their theory, the abnormal loading may be caused by a variety of factors, such as imbalanced muscle forces, abnormal postures, and asymmetrical brain input to either side of the spine as it's growing. These skewed messages are obviously more clear in a brain-injured child than why it occurs in an idiopathic adolescent. But we can appreciate that regardless of why these imbalanced inputs and forces happen, over time, they can lead to changes in the shape and structure of the spinal vertebrae, causing the spine curvatures to progress, which continues in a vicious cycle. So we get asymmetrical loading, we get asymmetrical growth, we start getting wedging of one side of the vertebrae where there's more pressure, which leads to the spinal curve and continues on with this vicious cycle of perpetuating the curve. So what we do know is, considering this information, it's important to appreciate that there can be a flexible postural component to scoliosis, influenced by exercises and postural corrections. I was just talking to one gentleman in here, and we were talking about, does the spine actually become rigid once the child stops growing? And rigidity is not necessarily a component of growth or of adolescence. Our spine is going to be flexible as long as we're moving. We stop moving, things become more rigid. But that doesn't mean that a rigid spine can't become more mobile if we work to mobilize certain areas. So as we see here, most cases, and therefore most research, is being done on our idiopathic scoliosis, which presents 75 to 80% of the cases of scoliosis that we see. Congenital cases include cerebral palsy or bony defects that have a very clear guideline as to what the treatment will be. And then neurological, the 5 to 7% of cases in between, that is generally where we see the spine collapsing in our brain injury kids. Unfortunately, our neurological cases are very rarely cut and dry. They are unique in their causes, severity of damage, and predictable outcomes. What is fairly predictable is how the spine tends to collapse unilaterally with one primary major curve, often 90% of the time occurring to the right and in the thoracic spine, leaving the lumbar and the pelvis to compensate under varying circumstances. So, because everything is not clear-cut, let's discuss some of the variations that we can see in our kids and how to recognize if they're happening. We classify scoliosis on the basis of age. Infantile scoliosis that happens between 0 and 2 years of age, juvenile between 3 and 9, and adolescents between 10 and 17. We do see adolescent or adult onset of scoliosis, but for our purposes here, we won't talk about that unless somebody broaches that specifically for me. We look at causation. We see neurogenic can happen in utero. We see traumatic, a secondary insult to the brain. Idiopathic is what we call of unknown origin, and de novo is our degenerative adult onset versions. We categorize it according to the Cobb angle. As I mentioned, the scoliosis is only considered a true diagnosis once the Cobb angle is greater than 10 degrees. Curves below 20 degrees are often considered low risk, but they are still in a very chaotic state, meaning that there's very little predictability as to whether or not the curve will resolve on its own or progress. This is why the medical community has traditionally adopted the wait and see attitude, so as to not risk panicking the family for nothing. In some instances, these curves under 20 degrees can resolve themselves. But what if the curve progresses beyond 20 degrees? Now what? Now we've waited to see, and we don't like the outcomes. Now they have moved into that moderate with 21 to 35 degrees of angulation, and now we have to start talking about bracing. Moderate to severe is anything between 36 and 40 degrees. Severe is anything between 41 and 50 degrees, which is usually where we start looking at consultations with surgeons, and then severe to very severe, anything over 55 degrees. So in looking at how idiopathic and neuromuscular are different from one another, it becomes apparent that we need to address each child as uniquely as their circumstances. Whereas idiopathic scoliosis is multifactorial without definitive cause, neurogenic scoliosis can often be connected to a specific date of causation that leads to abnormal nerve function affecting the muscles and how they support the spine. In idiopathic scoliosis, we see predictable patterns during rapid periods of growth, primarily to the right in the thoracic, but quicker to progress if it's found in the lumbar. Due to the early maturation process within females, scoliosis is more predictably seen in females 8-1. In neurogenic scoliosis, on the other hand, the spinal curvature causes the muscle weakness or nerve dysfunction rather than a problem with the structure of the spine itself. Because of this underlying neurological condition, it is often seen to be less responsive to bracing and therapeutic exercise, especially in non-ambulatory children. So how do we recognize the problem before it becomes a problem? First, we see that the treatment is going to be a team effort, especially with children that have brain injuries. A big part includes having all the professionals understanding what the family is going through and that all the family has the resources that it needs. The initial diagnosis is often made by a school nurse during a wellness check, a parent or a coach during an athletic event, or a pediatrician at an annual checkup. As part of that team and as part of a scoliosis specialized physical therapy, I joined the team to help the family and child focus on specific muscle imbalances, postural alignment, proprioception, and daily habit corrections that can encourage curve-specific pattern changes to help reduce and stabilize the curve. Obviously, with a child with brain injury, there are also a myriad of other specialists that will be taking care of the child, and it's important that we all work together and communicate so the family doesn't get mixed messages. One of the mixed messages that I want to make sure that I attend to right away is that scoliosis is a progressive condition. Whether it's idiopathic, whether it's neurogenic, we do see an average progression of 0.5 to 1 degree a year. So just because our child gets out of that pubertal growth does not mean that that scoliosis will stop changing with the spine. So why are the years before puberty and early screening so critical? Since the nature of scoliosis tends to be progressive, it's not usually a question of if the condition will worsen over time, but how quickly. While there is no predictive method to estimate the speed at which this will curve type, location, severity, and patient age all contribute to how quickly your child may or may not see progression. Thoracic curves are more common, but lumbar curves will progress more quickly. Neurogenic scoliosis affects between 7 and 8% of children and is not gender specific, but we do see it happen more frequently in boys 6 to 8 and in ages 13 to 15. Girls and boys tend to have their growth spurts, but we notice that a year before experiencing their first pubertal changes usually is the most critical phase of progression. And because we're never sure when this is happening, it oftentimes can be missed. So when we are at home and we see our child all the time, some of the signs of scoliosis that we can recognize seem obvious. But I can tell you through experience that many parents look back at frustration at having assumed that their kids just were sitting with bad posture. Especially as teenagers, it can be difficult to tell what is going on with your child's body because they very rarely are unclothed or bending forward in front of you. Some of the obvious signs we see is a head that's not centered over the body. We might see one shoulder that's higher. We might see one shoulder blade that's sticking out more prominently. We usually see gaps between the arms and the trunks when the kids are standing. If we see them from behind, sometimes we can see a curve, but sometimes we won't. Sometimes we might see our kids that stand more on one hip and have more of a prominent hip. It might just seem like a postural attribute of theirs, just kind of lazy standing, but it could be something else. The impact of scoliosis on the body is varied, and can impact each child differently depending on obviously the age, gender, and body tone. We see a lot of our scoliotic kids that start out with low tone and that are quite slender. But in general, the impact of scoliosis is consistent on our kids. We see compression through the joints, which can create shortening or shrinkage in the kids' spines. We often see flat backs, which make the shoulder blades appear more obvious on their back. We see convex versus a concave side. A convex is the side that sticks out, is more prominent, and a concave side is the side that's collapsing, where everything is being heavily weighted. We often see shoulder blades that stick out, shoulder asymmetry, shift in the body. Posture can be more difficult for them to maintain in an upright position once it gets a certain number of inches away from their midline, which means that their pelvis is now going to have to compensate. If they go over, it means their neck is now going to have to compensate. They start to create behavioral habits that perpetuate it because they are more energy efficient when they lean into their curve than they are when they stand up against it. When we look at clinical confirmation that we see in my clinic in particular, but in some pediatric offices as well, we have the first contact usually being the school nurse or the pediatrician. The first thing that one of us will do is called a standing forward bend test. A scoliometer, which you can see in the picture here, is a measurement that allows us to see surface rotation as we glide it down the child's back. There's all sorts of fun apps on the phone now that you can actually download that with thumb underneath your phone along the spine, you can actually create the same impact of the scoliometer. This is one of those things that I like to teach my parents, because if we see more than a 5-degree surface rotation, that's usually our cue to send them for x-rays. If you have a child that already has scoliosis and we already know what their scoliometer should be, then as we see movement, we can do this at home where we can slide that down their back and we can check and see if there's progressions. So sometimes the doctor may say, oh no, things are stable, that's fine, but you as a parent, you feel that something is changing. And this is one of those first steps that you can see if that scoliometer, if that little bubble in that scoliometer has changed more than 2 to 3 degrees, there's something happening to the spine underneath. When we bring kids into the clinic for physical examination, we are usually referred over by a pediatrician or parents that have found me. We do a very comprehensive evaluation of our kids, and we have them send over x-rays first. We'll do a 4-way postural alignment, so we'll look at the kids from all 4 directions of their body movement. So we'll look at respiratory tests to see how they're breathing and where they're breathing. We'll assess muscle strength to see if there's certain areas that are consistent with what we're seeing in the curve. We're going to have imbalances. Our body likes yin yang. It wants to see our front and our back, our side and our side. We want to see those muscles working in unison. And when they don't, we start seeing weak, strong, weak, strong. And so we have to figure out those imbalances to be able to get that postural integration communicating back with the brain. We look at flexibility. Brain injured children obviously are going to have contractures and different variations of different levels, but even with my adolescent kids that come in, hamstrings are a big deal. Hamstrings are always one of those first muscles that like to go into contracture. So we look at the flexibility and how that is impacting their body. As you can see in one of the pictures there, I use lasering so that we can see and measure how far off midline that child is standing. Gives us an idea of where that child's favoring, what side that child favors when they're sitting. We talk about patient and family goals. We look at their mobility, what their goals are for mobility, how we can help with that, and then we examine the risk factors that are within that child, gender, age, growth, puberty. We talk about those so that we know what to expect and how quickly we have to start acting on this information. As I just barely started getting into, some of the risk factors here are age. For a non-traumatic brain injury child, we see girls between the ages of 10 to 12 and boys between the ages of 11 and 13. Obviously, with a brain injury child, what I hear, as because there's not as much research on there as I'd like to be, what I hear is usually within the first year of brain injury. It doesn't appear evident right away, but within the first year, we start seeing some progression of factors that start rearing their head. Again, with gender, we see it a lot more in females than males as a maturation process and where the spine starts getting a lot of input. With skeletal maturity, one of the ways that we can tell where the child is in their puberty is called either a riser sign or a Sanders sign. A riser sign is a photo that's taking an x-ray that's taken of the hips as well as the spine, and we look at where the cartilage is growing across the crest. So in a mature adult, that crest would come out as a nice thick white line. But when we see it in children, we start to see that cartilage building from the outside in. And so that 5 stages tells us where that child is in growth. So if that child is at stage 1, then that means that we're probably a year before they're about to hit their pubertal growth phase. When they start to be at a stage 2, 3, we know that they're at high risk because their spine is starting to grow very quickly. Just to step back for a second, one of the ways that our children grow is that from the ages of 5 to 10 years old, most of the growth is going to happen in their limbs. Why we see scoliosis in this age range is because most of the growth in the spine starts to happen the year before puberty, which means that between the ages of 10 to 14 is where we see most of the growth happening in the spine, which is why we start to see most of the scoliosis within that time frame as well. So riser sign will give us a good indication as to where they stand in that growth phase so that we know what the risks are. The lower the number when they start to have a scoliosis, the more chance we have to control it. But if we find them with a scoliosis at 25 degrees and they're at a riser 3, we know that we've got to get that contained very quickly because they're in their height of growth. Now, the Sanders sign, which is not done quite as frequently, but is actually more of the gold standard, is an x-ray of the hand, because the hand and the cartilage that grows in the joints seems to be more consistent with where they are in their growth phase sometimes than with the pelvis. But those are both strategies that are important to understand. So if you hear riser sign or Sanders sign, when you're looking at the x-rays with the doctor, that's what they're looking for. They're looking for how close are they to this big growth spurt that's going to happen, and how much do we have to worry about progressing. If we get a 13-year-old girl that comes in with a 20-degree scoliosis and she's at a riser 4, then we're pretty sure that she's going to start stabilizing because she's gone through her big growth spurt. So when we look at the x-rays, which oftentimes, a lot of my parents will come in and they'll say they've seen the x-rays, but they didn't really have any conversations with their doctors, we look at where the spinal alignment is. The Cobb angle is measured by taking the most angled vertebrae at the top of the curve and the most angled vertebrae at the bottom of the curve, and then where those two lines bisect, that gives us what they're calling a Cobb angle, which is a combination to how far away that spine is deviating from their midline as well as rotation. So when we do a scoliometer measurement, it really gives us less than 50% of an idea what's going on with the spine, but it's easier to redo scoliometers than to send our kids into x-rays all the time. So we look at several things. We can see where the ribs are expanding on the right side. If we look at the x-ray to the far right, you can see how where the curve deviates toward tends to bring the rib cage open. And as the rib cage expands on that right side, it's also going to swing backwards. And so that's what gives kids that more prominent rib hump look on that side. We can see how the ribs on the left side start coming closer together. And especially with neurological kids, the picture inside of that one, especially with our neurological kids, we start to worry about respiratory issues. Right, but the research right now is showing that unless we have curves that are greater than 90 degrees, there's not a lot of compensations happening for the respiration. Now again, this depends on whether or not, kids have other respiratory things going on, whether they have poor O2 exchange, whether they have poor breathing through their sinuses. So all of those are just giving us ideas about the scoliosis is not specifically imposing upon that. But we could see shortness of breath in kids that have less than 90 degrees if there's other things going on. So our traditional approach of wait and see just doesn't work for us anymore. But what we do know is that scoliosis is diagnosed when a curve goes beyond 10 degrees. We know that small curves are easier to treat. We know that curves below 20 degrees are still considered in a chaotic state, and that means that they could get better on their own, but they might not. We know that when we have them at 20 degrees or less, that we have a better opportunity to improve the spine than without intervention. The age of the child and the maturity play a part in the progression of the curve and the risk factors that their curve will and can progress. Curves smaller than 20 degrees are generally thought to progress in only 60% of idiopathic cases. However, with traumatic brain injury, we know that that increases to more about 80% in our kids. And few resources have been given to this population. Right now, based on the research articles from the Scoliosis Research Society and the last SOSORT paper published in 2016, and SOSORT is the International Society on Scoliosis Orthopedic and Rehabilitation Treatment, we know that conservative treatment guidelines are the new norm to our just wait and see approach. Performing low-dose imaging, such as that found with the EOS machines, is also another suggestive that we work with these kids that are going to have to get multiple x-rays. The EOS is known as a low-dose x-ray machine, and those right now, I think there's only 2 in Austin, but they tend to provide better three-dimensional imaging with less radiation to our kids that have to get frequent x-rays. So at this point, when the curve is between 10 and 25 degrees, we usually consider exercises, re-x-raying every 3 months if there's a change in the curve of more than 10 degrees, or re-x-raying every 6 months if there's less than a 10 degrees seen. With moderate, 25 to 40 degrees, this is the point where we start having a consultation with the orthotist, because the bracing is always going to give that leg up. And we talk about bracing when kids still have the opportunity to growth, because it's like we're supporting a little tree sapling as it's getting taller. And so this is why usually if the kids are beyond 14, 15 years old, we don't see doctors putting them in a lot of bracing, because bracing is not intended to correct in a spine that's not growing. And now I do see a lot of adults, and I think that for function and for pain, I think that bracing has good impacts, but it wouldn't be 21 hours a day like we put in our kids that are growing, that really need that stabilization and the unloading of the spine, as that spine still has an opportunity to shift and change as it's getting taller. Once we have a scoliosis over 40 degrees, there's usually an orthopedic consult that's suggested and surgical options with reevaluation. I always tell my parents that though the research suggests that beyond 45 degrees is the time in which we should talk about surgical consultations, I think quality of life is a big thing to talk about too. And are we talking about, does the child have pain? Does the child have breathing issues? Is there quality of life issues? If those things are not at the top of the list, I think that we need to be very careful about just jumping into surgical option just because we've hit a certain number. I have a lot of people that I work with, a number of kids actually, that are in that 80 to 90 degree range, and they're doing great. So let's leave them doing great, doing what they can, doing what we can for them. Surgery will always be there. Surgery will always be an option. And so I think a lot of these consultations tend to frighten parents into the idea that if we don't get them into surgery before their spines fuse, that's it. And we're not seeing that the outcomes of surgery are more than 50% reliable and consistent for quality of life afterwards. In fact, I see a lot of post-surgical people. So I think there's a lot more things to consider when we look at surgery than just the fact that we've hit a number. So a little bit more specific about why I'm here, what I do, my specialization, and where it started was with a method called the Schroth method. The Schroth method may be something that you guys are hearing for the first time. Maybe it's something that you guys have looked up. It's actually been available to families in Europe for the last 200 years. Unfortunately, it has not been credentialed here as a treatment option since 2008. Katharina Schroth was the first person out of Germany to really talk about what we do with these curves, how we create expansion in postural, in position, in breathing mechanics, to be able to take a child who is completely collapsing on one side and get them to use their body and their limbs to be able to position themselves so that, as you can see in that picture of before and after, we can actually encourage breathing into spaces that are not getting air if we adapt some positioning. The principles of the PSSE, or physiotherapeutic scoliosis specific exercises, is what is the underlying principle for a number of the European credentialed scoliosis schools. And we talk a lot about autocorrection, which means that with some of these kids, passive correction is going to be more appropriate. If a child at all has communication, has understanding, then that version of autocorrection, allowing them to assist to help expand their bodies from the inside out, teaching them how to use their muscles to be able to do that, teaching them how to sit properly, teaching them how to be supported properly. We think about three-dimensional postural alignment, so posture not just from the collapse, but also posture forward and backwards. Are they sitting forward all the time, compressing on the front of them? Are they sitting in an arched position where they're collapsing through the posterior side of their lungs? So that spinal elongation, to try, imagine that you had a string that was collapsing in on itself and you took the string from both sides and you brought it apart. There is availability of getting some correction just by having that auto elongation and that expansion happening within the spine. Each program that we work on is individually designed for each person and their unique circumstances. And obviously, with a lot of what we do, we try to integrate all those activities of daily living to make sure that it's not just here's an exercise, but how do you live? How do you integrate this into your day-to-day activity? And then if the child has a desired recreational or activity, because we like to see our kids being active at least 4 to 6 hours a week if at all possible, then we try to assist in how that curve correction would help if there was some sort of activity that they're involved in. So we work on stabilizing the spine through a variety of measures. You can see here with Alex, who's my patient that is wheelchair bound, that he's able to get out of his wheelchair. He is able to lie on his back. So we create stabilization through the use of him being able to hang on with poles. We create stabilization through having a belt around his knees so that he doesn't have to worry about controlling his lower body. We create neuromuscular exercises to be able to get him to start to feel how he can move his body separate from one another, so it's not just an all one kind of rolling or sitting position. How does he separate his pelvis from his shoulders, from his trunk? We work on proprioceptive training, eyes open, eyes closed. Where are these kids in space, and how can we get the brain to start paying attention to what midline is instead of letting them feel that slumping off to the right side is midline for them, and then everything else has to support that. With our kids, as best as possible, we try to work on balance training. So even with our kids that are in wheelchairs, being able to get them on some unstable surfaces. A big part of what I do, you can see in this picture back here, is we have wall bars. We have wall bars that allow for a lot more stability because the child has somewhere to hold on to if they can't hold their body upright, but they have grip strength. And so We begin balance training, unstable surfaces, movements from being able to control their core to can they control leaving one arm down, can they control one leg coming up. We adapt for whatever the kids' needs are on that. And then ADL performance and integration, so activities of daily living. What's happening when they're in their wheelchairs? How are they able to lean forward? How are they able to eat? We'll talk about sitting, standing. So in standing frames also, how are we able to support their curve corrections if they're in a standing frame? So you'll see the basics of these exercises are understanding what kind of curve pattern we have. Do we have an upper back and a lower back curve pattern? Do we have a back that curves to the right with the pelvis and the low back going to the left? So each curve has its own fundamental basics, and then from there, those exercises are defined more appropriately for each child that I treat. Scoliosis-specific exercises are also valuable during bracing, because the brace is supporting the child's change, but if we don't teach the child how to sit into their proper posture while they're in bracing, what we end up seeing is kids that have a lot of bruising. They really work against their brace, they get too much rubbing, they get soreness, then they hate wearing the brace, and so it's this vicious cycle of they need to wear the brace, but they don't want to wear the brace. And so we help the body understand where to find its middle ground, which also unloads their body while they're in the brace, so they don't have all those pressure points and sore areas. We also will use scoliosis-specific exercises in prehabilitation. Like anything else, when we look at somebody whose body needs to be strengthened before they go into surgery, the surgeon is just going to change what's happening to the spine. But what they don't change is what's happening to the muscles. The pushes and the pulls, the muscle imbalances, those are still there. Those are still trying to pull on that fusion after the surgery. So if we don't create an awareness of this child of how to correct themselves, how to be stable, how to create better breathing patterns, then when they come out of that surgery, they've still got the underlying soft tissue that is going to start to pull against that fusion. And so we like to look at what we do in the prehabilitation side of it as also helping with those surgical outcomes being more efficient and effective, because the child's body is not going to be working against that nice bony alignment that the surgeon has just provided for the child. And then, of course, post-operatively, when we look at children that come out of surgery, if they have not had an idea of what's happening to their body, it's not too late to show them this is what's happening to your curve, because though the spine has been straightened, as you can see in that picture to the left, he still doesn't know where he is in space. His awareness of where his body is in space, or what muscles are working, or how to change his sitting, standing, sleeping postures haven't changed. His habits are still there, perpetuating that muscle imbalance that is going to pull on that fusion. So we continue to work on establishing that alignment, that balance, and that stability so that that child can make the most from the outcomes of the spine that's now not working against them. Oftentimes, I'll have parents ask me what the difference is between traditional physical therapy or between just keeping my kid active. And so though we want normal physical activity to definitely be part of their lives, a lot of research suggests that scoliosis is slowed or at least stalled with kids that have 4 to 6 hours of physical activity a week. We do know that sports are generally not curve specific, right? We need to work these kids in a curve specific manner so that we're working them asymmetrically so that they're getting what they need beyond those activities that we're trying to keep them active, especially when they're wheelchair bound, to keep their bodies moving, to keep their muscles healthy, to keep the blood circulating and healing various areas. Physical therapy, scoliosis specific exercises are also provided just by physical therapists at this time, and it takes us up to 2 years to gain a certification in this. So this isn't just a weekend activity where we go out and we do cupping and all of a sudden we know what we're doing with cupping. This takes us about 2 years to be certified to be advanced in scoliosis methods. We have to relearn the body in a totally new way. I've been a physical therapist. I had been a physical therapist for 18 years when I started working on scoliosis specific patients and learning this certification. And I was humbled by how poorly, as traditional physical therapists, that we are taught how to deal with a spine that's not straight. And it was very eye-opening as to how much we are taught as traditional PTs that does not flow when it comes to our neurological kids, our congenital deformations, our scoliosis. So it is really important that a scoliosis-specific certified physical therapist is working with your child if you choose to do some sort of physical therapy, because traditional physical therapy does not look at the spine. Oftentimes, one of the more common things that I see happening, because we haven't been taught in education to do anything different than the 7 pages of our orthopedic practice that has been out there for 40 years. So what we're often taught is, oh, the curve goes to the right. Let's just lie them over a ball and they can stretch their left side. What that doesn't take into consideration is the fact that our ribs are in the way of that thoracic spine. So bending them over the ball to the right to try to unload that curve, all that does is it actually just compresses those ribs forward and backward. We don't get into the spine at all, and that gives them more breathing issues. And so we have got to treat the thoracic as a part that needs to be unloaded with gravity. And we'll talk about that in our positioning. So some of the daily functional accommodations that I'm going to address here, just in really general terms, so please feel free to ask me anything specific after the presentation, is what's the best way of positioning our kids for sleeping? Sitting, standing, strengthening, and then some general strategies. When we look at sleeping positions, what we know for sure is that we do not want to put them on the thoracic side of the curve. If we put them on that thoracic side of the curve, all we are doing is impacting the ribs. We must put them on, for this purpose, we see 90% of our curves going to the right. We must put them on their left side. That left side allows the gravity to open up those ribs on the left, which we saw earlier were closing down, and it also allows gravity to pull the spine down into its natural position rather than us trying to push up through ribs to try to reach a thoracic spine that we can't reach. So positioning on the concavity of that thoracic side is of primary importance. Trying to maintain some alignment, being able to put a body pillow between their knees so they have something to hug so that their pelvis isn't falling forward. Good pillow support, obviously, we know this for our kids. If we have a kid that has a pelvis that is having to compensate quite a bit to the left, oftentimes we'll put a small little blanket underneath their pelvis to actually help bring their pelvis back into a neutral position, which gives even more space for that thoracic to straighten and come back to gravity. Because as we know, we're not sleeping on hard beds, and we don't want to give our kids sores. So especially with our non-ambulatory kids, it's easier to lift the hips up than it is to let the body just sink into its natural frame into the bed. And then this is one of those precautions, but I do talk to people about avoiding prolonged support under the knees when kids are lying on their backs. You know, we've got problems with contractures already, so though it supports the back nicely, the longer that they sleep in an upright position or with some support underneath their knees, the more problems we're going to have with hip flexor contractures and contractures behind the knees with the hamstrings. Obviously, some of our kids, that's just what it is, and that's their comfort position. But if we have kids that aren't there yet, then it's good to try to support as much as possible, but as little as necessary. When we look at sitting positions, I've worked tirelessly with Alex on trying to get better wheelchair accommodations, and I wish I had better information on this because it does not seem like anybody is making a good wheelchair out there for these kids, especially with kids with scoliosis. But what we try to promote is that opening up of the thoracic concavity by elevation through that right arm, opening up that right chest. When we think about a chest that has rotated back on that right-hand side, it's also rotating forward on the left. So having that support behind the right ribs helps to derotate and bring those ribs back on that left-hand side, helps with respiration, helps with positioning, and also having that arm up and out of the way helps that shoulder blade come forward to allow for those ribs to come back better on that left side. Also, when we have, like you can see with Alex here, he has a very strong tendency to lean to the right, which puts his pelvis to the left. So what happens when we lean our kids up and to the left, our pelvis goes to the right. So it also helps with better spinal alignment with being able to support our kids. Now, again, like I said, haven't seen a wheelchair that does that. So best we can hope for is to just get our kids, sometimes there can be tray additions that can be added to that left side, but if we've got kids that are needing to roll their wheelchairs, then it's more, with Alex, I just try and really talk to him more about, awareness in his positioning and not, he likes to throw his right shoulder over the back of his wheelchair, which goes into his curve. Simple things like, okay, well, if you're gonna do that, left side goes back so that your ribs can come back with you. Ensuring the seat pan is long enough for the underside of the legs is another thing for a lot of these kids, because they don't seem to measure these seat pans very well. And we should have, just like when we're sitting in chairs, we should have no more than 2 to 3 fingers width from the back of our knees to the beginning of where the chair starts. Otherwise, those kids are either getting too much pressure up against their knees, which is making them kind of slide down, or it's not long enough to support the legs and they're sliding out. And so they end up also getting this rounding of their low back, which creates more kyphosis through the upper back, which creates more rotation. So the way our spine will work is that once those vertebrae have reached the maximum flexion of where they can go to, they can't go any more into a flexed position. They start to slide off one another, and that's what creates more rotation. So the more flexed our kids get, the more twisted they'll also get. Asymmetrical back foam may be one of those suggestions that I give to parents about trying to support through that right side to push those ribs forward, but hollowing out that left side to allow the ribs to come back on the left. And then good leg support, obviously without shortening the hip flexors. Alex's sports version of his wheelchair has his hips lower than his knees. And so when he's in this position, of course you're going to get more contractures through the hip flexors, more contractures through the knees, because his butt is sitting down. And I know that a lot of people think, well, that's to stabilize so that they don't slide out of the seat. But at the same time, we have to find a happy medium where the kids can sit with their knees level with their pelvis and not have that pelvis sinking down, which changes the position of their pelvis, which changes the position of their upper back, which changes the position of their hips, those kind of things. Standing frames. I'll be the first to admit I don't have a lot of experience with standing frames. I've been to Alex's house, so I've seen a lot of his toys and what we added for Alex, because he has a lot of forward flexion. He's got a lot of contractures through his hip flexors, so he's got a lot of forward pelvic movement. And so the best we can get with Alex's knees being pushed back in these standing frames is to add a little bit of an extra foam pad in front of him, so that we're at least not letting him completely sag on his tray, and that he's got some support that's trying to keep those ribs back so that he's not just collapsing with his ribs flaring forward. Obviously making sure that he has adequate workspace, raising up laptops and iPads in an ideal world on an angled surface, so that the kids are not having to look down on a flat surface, but have an angled surface so that they can, where the head goes, the body follows, right? So the less that we can have them looking down at a flat surface, the better. Supporting, again, under that concave arm with pillows as we can. If we were to pull down that side arm for Alex, and we had the ability to, tape a couple of yoga blocks over to that armrest. Now he's got an arm position that he doesn't have to work so hard on, being kind of elevated to open up those ribs on the left side. Strengthening using scoliosis specific exercises. Again, looking at what the child can do and adapting it as such. only having them laying on their concave side, as you can see in that first picture, which allows Alex's ribs to open up. I've got him on an elevated surface, which is bringing his pelvis up as his ribs are trying to come down and stretch. Being forward over a ball with stabilization so that he can work on some shoulder blade movement in a less gravity dependent position. Having him sit on a BOSU, which is a balance tool, while holding on to the bars and being able to actively engage some muscle work. Having him do some strengthening of his shoulder stabilizers with or without tools. These are all some of the ways that we've adapted the Schroth method to be applicable for Alex and his inability to actually participate in a lot of lower extremity use. So general strategies for care, which I'm sure will be things that you already know, but regular medical checkups. Scoliosis-specific exercises to help strengthen the muscles around the spine. Avoiding high-impact activities or lifting heavy objects that compress the spine. Obviously, we're talking about in our higher level kids. Twisting or bending at the waist. Gentle stretching can go a long way to improve flexibility and reduce contractures. Health nutrition, maintaining good diet, bone density, those are all really critical for their overall health as well. So with all this information, what do I feel like the most important points are that I hope you take out of this? I want everyone to remember that scoliosis is no one's fault. It can no more be recognized before it happens or prevented from progressing if that's what the body truly intends for it to do. Our role here is to help improve the messaging of the brain to the body and to understand what the risks are to each child based on their age, growth, curve pattern, and muscle imbalances so that we can intervene as soon as possible. In consideration of other medical conditions, obviously, that are underlying. However, we have found that some steps that can help reduce the risk of developing severe scoliosis do include early intervention, trying to get to these kids and manage positions, postures, sleeping, standing, sitting, supports when they're less than 20 degrees can make a big help. Maintaining good postural alignment and body mechanics, engaging in regular exercise to promote good muscle tone, and eating a healthy, well-balanced diet. Whether or not scoliosis-specific exercises can help a specific child curve once it's going down that rabbit hole, we still need a lot more research to gain a better understanding and undeniable clinical evidence as to exactly what needs to happen when. What we can appreciate is that there is no evidence that doing something and doing it early comes at a greater risk than doing nothing at all. If I can promote a child's understanding of what's happening to them, improve their muscle tone and balance, increase a child's self-esteem and confidence while working against the progression of their curve, then I feel like I've done everything I can to contribute to the betterment of their quality of life. Thank you. And I'm happy to take any questions you guys have. Okay. Okay. Mm-hmm. Yeah, it's common to think that. Yeah. Yeah. Okay. Of course. Okay.
diagnosis from a pediatrician and get him to send us to, I don't know. Versus, I don't want, you know, if we can exercise and help take care of this,
Mhm.
that's what I'd like to do. I don't know where to go.
Because of how young she is, one of the things that I do offer with my parents is to come in and have her assessed, right? Because if you can hold her while we do some scoliometer measurements and we see, okay, this looks like what it is. Let's see how she wants to sit. Let's see how she wants to lay down, those kind of things. Then we can kind of see where some biases are happening. If we think that there's enough of a scoliometer measurement, then I would definitely suggest, what's the harm in getting an x-ray done for her today, right? It gives us a better indication as to what we're going to expect. It gives us knowledge, and I think knowledge is power. And so but if I don't see anything when I assess her other than muscle imbalances and biases, that will also come out too. Because we're not just looking for a sideways curve. Sideways curve can sometimes be postural muscle tone. What we're looking for is that side bend and the rotation and the body changes in conjunction with that. So sometimes clearing that up before we send them for an x-ray is important. And then depending on what we see, especially if you come in with a child with their chair, then it's easy for me to say, okay, look, this is what we need to look for. This is how we need to stretch her. This is how we need to position her when she's in her chair. Let's support her here. Let's work the arm this way. Let's move her head that way. Let's do this with her legs and those kind of things. Or, I will also work with the pediatric physical therapists that are working with them. And I've done kind of conjoint treatments with their physical therapist or their PTAs to really help to educate them on what's going on, because obviously, that physical therapy component is very important, but what's lacking is not the desire for your physical therapist or your physical therapist assistant to want to do the right thing, but we're just not educated about it in regular schooling. And so that seems like the right thing to do, is just put a towel under her right side. But definitely, if you're seeing something starting to collapse over to the left, then you want to stretch that side out. You don't want to try to push anything with the spine. But if you have questions about it, that's where having somebody such as myself look at her and do an evaluation can help you with figuring out what the right postures are, what the right positions are, the right way to stretch her, the right way to move her, those kind of things, to be able to help kind of stabilize things and make sure that as much as you have any input into what the brain is talking to the muscles about, that you can at least slow or stall anything that's going to happen with the spine. Obviously we only have so much input, but at least doing the right things to help will give you peace of mind that you're doing everything possible, instead of this just being, to your point, it's bottom of the list. Yeah. Okay. Anybody else? Yes.
So would you mind explaining just one more time the convex concave? And so just kind of similar to what you just explained about, so because it's so hard to determine when the child's twisting
Yep.
in the chair, which side is truly the side that you want to support versus the side you want to stretch?
So with most of our brain injury kids, the ribs are kind of a giveaway. So we look at rotation as, imagine they have headlights on their chest or their pelvis. Which direction are the lights pointing? Okay, so we determine rotation not by the spinous processes at the back of the spine, but by the chest itself. And so 90% of our kids rotate to the right, because a lot of our scoliosis will actually move away from the heart, because there's a lot more taking up space on the left than there is on the right. That's a theory anyway. But we do see 90% of our scoliosis is happening on the right. And so when the scoliosis starts to pull away from the right side, because the shoulder blade has to get out of the way, you'll also see that shoulder come up on that right side, because the ribs, as they twist to the right, are rotating backwards, because our rib cage is not circular, it's oval. And so as it twists to the right, we're going to see the prominence in the right back and the left front. And that's kind of your indication that you've got that right rotation. Then add to that, the shoulder blade is trying to get up and out of the way, and now you've got an elevated shoulder on that side. On the right side, because the shoulder is getting out of the way of where the ribs are rotating back, right? Think about the shoulder blades as being football pads on a football player, right? So the ribs go back, the ribs go back, and the shoulder blade has to come forward.
So the headlights are pointing towards the right.
To the right.
The chest is going
Yes, exactly. Exactly. Yeah, and
to
so,
the right,
and
shoulder up, with shoulder up.
the ribs are going back, which is causing the shoulder blade to come up and over the rib cage to get out of the way, because it's not part of the skeleton. So it has to get up and out of the way, because as the ribs rotate backwards, it's not just going to expand backwards with it. So it has two choices. It can go up or it can go down. But we've got 17 muscles around that shoulder blade and neck that are going to determine its bias, which is it's moving up and over the hill as the mound or the sand dune is growing bigger. Yeah, yeah.
So, you would position for sleep on which side?
So always on the concave side, which is the side that's collapsing, so the left side. If we have a right rotation and the ribs are, as they twist, they expand like an accordion and sink backwards. So we want to put them on their left side so that we can allow that stretching to bring the spine and the ribs opening of their own volition without trying to punch through it, which is what we'd be doing on the right side. So it would be laying on the left side. Yeah. Yeah, if we have a right rotation, a right thoracic, we're going to want to lay them on the left side. And if they have a significant pelvic and lumbar compensation to that left side, then I put a blanket underneath the pelvis on the left side so that we don't, all the stress is not going on the rib cage, but the ribs and the hips are kind of coming up to meet one another. Yeah. And then with the arms, we want to get that shoulder blade back. So that's why I like to have body pillows, something that they can hug on. Same for all my adults with back pain, right? We want to have our body be able to be as aligned as possible. And so with our shoulders being wider, if we don't support with the pillow, our shoulders start to collapse forward. The more that the shoulder blade collapses forward on the right, the more it pushes the ribs back on the right. So it's defeating the purpose if we don't bring that shoulder blade back. And then between the knees, we don't want that pelvis to roll to the left, which is where it's already rolling. So blanket underneath the left side helps to keep those hips back on the right. Expand.
So there's certain DAs or equipment companies that are now carrying sleep systems.
Okay.
That are positioning systems.
Okay.
Where you can change the positioning. They have like pommels,
Okay.
and you can actually change it to position the child and put like a pommel between their legs or put it up against their back or behind their hip.
Okay.
And they have different ones that you can purchase, and it's on like a sliding system.
Okay.
So you can move it around, but it's not super easy to change it in the middle of the night.
Right. Yeah.
So it's kind of like if you put it in and lock into that system. So it makes it difficult to change position.
So the positional changes should be primarily, in a perfect world, between the back and the left side. Okay, we don't want them going to their right side. Their right side is, they've got this opportunity while they're sleeping at night for their body to relax and grow. We don't want to put them on a side that's going to perpetuate that rotation of that right side. So without having seen that, I don't know if the bed is wide enough to have the sleep system and to have another little area that they can roll onto their back and position. In a perfect world, I would think that if you had kind of a double bed of sorts, if you have the sleep system on the right side, and then when you want to change positions, you take them out of that, but you just roll them on your back behind the sleep system, and then they can roll back onto their side into the sleep system. Does that make sense? Now, not having seen that, I'd love to, take a closer look at it. But I also do, with my previous patients, I've also, gone to their homes, because I know there's a lot of equipment that you can't take with you to a PT office. So if there's something I'm really confused about, and it's integral to the care of the child, I will do a home visit to see what's going on. So yeah. So it sounds promising, as long as you can put the child on the left side and, like I said, have a bed that has enough space maybe behind it that you can roll them on their back to change position. Anything else? Yes.
I have a son, and he's, the doctor's trying to say that they look like they're starting to have that scoliosis, but they're saying they're starting.
Okay.
And then I remember when we were in the middle of our accident, we were staying at the Ronald McDonald house, and there was this little girl that came in, and she has the scoliosis, and she was telling us that, man, if you could ever have it where you can take your son to a chiropractic, someone that knows how to adjust, it would help so he doesn't ever have problems, because she said on her end they were waiting, and then her got to the point where it's severe that now she can't go to the chiropractic. So my question is it okay that we be taking him for a chiropractor to have him make sure he keeps adjusting and try to keep him straight and on line, or are we supposed to just sit and see what happens?
That's a loaded question. I, like anything, there's good and bad in every profession. I know in the physical therapy profession that we've got the scoliosis specialists. There's not a lot of scoliosis specialists in the chiropractic profession. There may be some people that kind of, they know the body, they know the spine. In a lot of my scoliotic kids, we are more focused on stability. And I feel like on a very superficial level, chiropractic provides mobility. And I feel like there's a lot of value to what they provide, but I can't speak to exactly all the depth of what their adjustments are providing. My only fear for a child would be, how does a spine get stability if we're constantly flexing on those ligaments, if we're constantly adjusting against those end ranges? Great, we've got this spine, but now how does that spine stabilize when it's up against gravity, right? So I usually tell my parents, if it helps you sleep at night and you like that and you feel like you get good results for it, don't stop it. But there has to be some strengthening on top of that as well, and you're not going to get strengthening from that chiropractor that's going to be curve pattern specific. So I would say there has to be a little bit of both in there. If you're going to go to the chiropractic, then there has to be some scoliosis specific exercises tied into that as well, so that when the child gets adjusted, then you can help them work on how to maintain that adjustment by their own body strength or their own body input. Yeah. Okay, I think, yes.
No, go. I just got a quick question. So you mentioned that the foam for the backrest
Mm-hmm.
for the wheelchairs.
Yeah.
Is that something that you purchase? Can you just purchase it from the local?
Yeah, I haven't found anything that's like curve specific. So it's one of those things where I get real creative with my kids, and I make sure that, we just try. We just try it. We get creative. We get fancy. We throw things into a pillowcase, Velcro pillowcases. Those are all good stuff. It really is curve specific for the kid. You need to then you need to kind of put it behind them, and you need to like see what that looks like. I've even at one point gotten with one of my parents that was really, she was a good sewer. We would actually sew pockets into the back of t-shirts and pad inside the pockets so that we didn't have to worry about something extra going out. I like that idea, but there's never enough time for good ideas. So yeah, it's one of those things where you pad, you look. What does the kid look like? Okay, it needs a little bit more there. You got to make sure it's below the shoulder blade and just on the ribs, because we want to allow that shoulder blade to sink back down. So whatever we prop, we don't want it to just be on that right side. We want it to be underneath the ribs. Yeah, on the ribs, underneath the shoulder blade. But you look, and you're looking for symmetry. So what provides symmetry? Yep. Yeah.
Really quick,
Yeah.
show you a picture of my son.
Yeah, for sure.